This is the 6th session in the 4th annual Social Justice Speakers. We've had great speakers from Seth Holmes to farm workers and several other people in between. We're going to end with several speakers who will provide additional information, but also have a focus on what the solutions are, what's currently being done today as far as policy to resolve some of the problems that people of Indigenous and immigrant communities are experiencing, but also what you can do as public health practitioners and clinicians in your practice. So ultimately, what we want to leave you with are tools, possibilities of where you can plug in. And so our first speaker is Mr. Leoncio Vasquez. He's a founding board member of the Central Valley Immigrants Integration Collaborative, a regional network of organizations that have come together to serve immigrant families residing in the Central Valley of California. He is the former executive director of Binational Center for the Development of Oaxacan Indigenous Communities, which was created to serve the indigenous migrant communities from Mexico, primarily from the state of Oaxaca in that country. Since 2006, Mr. Vasquez has played a key role in organizing a Year of Immigrants' Rights March in Fresno through the May 1st Coalition for Immigrants' Rights. Invited by the Fresno City Council president to work alongside other stakeholders, he is part of the Southwest Fresno Specific Plan Steering Committee as well. Please welcome Mr. Leoncio Vasquez.
Aku kwenzi kwindo. Aku kwenzi kwindo. Ukano ini dona kai yo bitung sindo. Tunya kai cha tunda binanya. Tun savi cha ta tun ru kwanja na rivi na ka tun savi into nyung ro. Chando na ka sa kubita nya kundai ni donya. Baso no corroi che si da cha isu tung sa kai tung mi kunya kai. Good evening. I like to start this way just to recognize that the land we are sitting on right now belongs to the Native people. And we need to recognize that. I am one of the Native people of this continent, and even though we have migrated to the United States many times, because of language, of culture, we face different barriers, and that's what I'm going to concentrate on right now. I came to this country when I was 17 years old. So I went to high school. I started going to college. I dropped up and then started to work with this organization, the Binational Center for the Development of the Indigenous Communities. At that moment, it just got started. So when I started to work full-time, we put a lot of effort to build the organization from zero. Many people were not aware of who we were. They just assumed that we were Mexicans and that we needed to react, behave as any other Mexican they have seen before. Even the Mexican communities were not aware of us, those coming from the north part of Mexico. So let me start. Hopefully this will work. With this. When we're talking about culture, what do we mean by that? And I'm sure you are aware that that's basically what we learn throughout our lives in one particular place that we live in, that we grow up, the people we grow up with, the language, the food that we eat. So when I started to work with this organization, I started to hear this term, cultural sensitivity. And in the health, in the social world, I'm sure it is known already. Basically, to be aware or have the capacity to understand and value other people's culture. But also, there's another term that goes beyond just be cultural sensible. Is that how you say it? Cultural sensible. And besides just be aware or value other people's culture, go beyond that, especially in the health sector, in terms of combining what you know throughout your school years and what belongs to the community that is worth it, the value that they value, and the way that they want to be treated to deliver the services. Combining even their values, their cultural identities, to serve them in a meaningful way. And now I'm going to just show you some numbers from the census. And I'm sure you are already aware of the changes that is happening in this country. This is starting with the 1980 census, and as the darker it gets, that's the changes that we are seeing with other communities. The 1990 census, 2000, 2006, and that's how we started to talk about the diversity of culture in the United States. Those are the population in those different states and the numbers of especially Latino or Hispanics. But we're not just talking about Latino or Hispanics. And that's the reason that I'm here. I really thank the organizer of this event for inviting me. I'm coming from Fresno. I'm honored to be here and talking to you about especially who I am and the 15.7 millions of indigenous people in Mexico, Peru, Bolivia, Guatemala, the different numbers of those of us that still identify ourselves as indigenous people. That is Mexico. What I'm going to talk about mostly is Oaxaca. How many of you are aware of where Oaxaca is? Raise your hand. A small number. When we're talking about indigenous communities, that is the green part in the map, on the map. In Mexico as a whole, there are 62 different indigenous languages alive in our time, right now. And as we are talking, maybe one or two of those languages are being vanished because there are not many people that still speak their native language. When we're talking about my state, the state that I came from, the state of Oaxaca, is a diversity itself in terms of language. There are 16 different languages that we speak in the state of Oaxaca. I happen to speak just one of those languages, Mixteco. And I highlighted the first languages. Those are spoken by immigrants that are in the United States. And probably every year we get new immigrants that speak other languages. So when we're talking about indigenous people, why do we say indigenous? Some people say that we want to be different, that we speak a dialect of Spanish, and that we want to separate ourselves from the Mexicans. The fact is that we have been in this continent for the last 8,000 years, at least. We have culture, we have millenary language. Our social and political government was and still is different in our days to what we know of the government, the social system in this country, in Mexico as well. When we go to the indigenous people, we ran ourselves very different. The history has been that there have been cities, states governed by royal lineages in hierarchical social structure. Our civilization was very advanced in many forms: art, literature, math, cosmology. The close nature, or the closeness with nature, the use of traditional medicine. That's the way that we heal ourselves, not through Western medicine or what we know or what you are studying right now. The practice of traditional medicine. That is a very quick glance of the history of the indigenous people. 6,000 before Christ. That's when basically our civilization started. With the Olmeca, Tolteca, 200 years before Christ. It was flourishing by that time. And then 850 after death, that's when our civilization was declining until the conquest of the Spaniards in the 1400s or 1450, 1492. Our civilization was very good at organizing themselves. We will say that we invented the free education system, health, and the food system. Our civilization invented the corn. That's our contribution to the society. Buildings, pyramids, that you can still see right now. How many of you have gone to Oaxaca? Have you been to Monte Alban? I'm sure people just go there for the pyramids or at least the colonial look of Oaxaca. We have our writing system through the Mystic Codex that basically kept the history of the Mixteco community at least 4,000 years. The following are some of the different concepts, very different from what you know, of how we organize ourselves. The traditions that we have of El Tequio. El Tequio basically translates to collective work for the benefit of the whole community. Every time that we need to fix a road, to build a community center, a church, a classroom, the whole village get together to make sure that that project gets done, because we don't receive anything from the government. Our religion is we are Catholics, we say. But every time, or 2 or 3 times a year, we go and ask for the well-being of the community, of the family members, to the God of rain, Savi. That's how we call it in Mixteco. And that has been the religion that we even still mix with the Catholic religion. Gelagexa, we like to show off the richness of our culture, our food, our clothing, music, dances, at least once a year, inviting other community members to have the same celebration. Fiestas patronales, that's the most recent one, is based on Catholicism, celebrating the same dates. Dia de los Muertos. Every Mexican household celebrates Dia de los Muertos every 2nd of November in a way that is very deep to us, because we basically think that the spirit of loved ones who pass away come back on November 2nd. So we build our altars with the best that we can provide. The use of traditional medicine. We have belief systems that is very different from the Western beliefs in terms of how we get sick, but by strong, very strong emotions. And how we believe that every area in our land belongs to someone, something. And every time that we want to utilize, that we want to work that land or cut a tree, we need to ask for permission. Otherwise, we will suffer the consequence of an illness. And then we go with it through a traditional healers to get well, to get healed. And just in the Western medicine, we have experts in every field of our medicine. Herbolarios, those who work with herbs. Midwives. That's the only way that we deliver babies in our communities. Hueseros, treatment for bone problems. Sobadores, spiritual guides. So they have expertise in every area based on what they have learned from generation to generation. Some of the value system that I want to share with you, and probably this is going to, hopefully, when you get finished with your career, you go out and work, get in contact with people that may behave differently, that may speak another language. Some of the signs that to be aware of, that in the indigenous community, we have very strong value system. We support each other. And we like to know every member of our community. And since our villages are very small, even though we migrate, we search for every member of our community to be in contact. And just with my village, When someone died, in a matter of 2-3 days, we gathered $10,000, $12,000 to deliver to that family so they can do with the funeral expenses. We don't go to the main point at first. That's very important for you, because here we go fast. We go by the clock. You are assigned to see, I don't know, how many patients, how long. When you get to see an indigenous person, they don't go to the main point. They talk about family members. They talk about what happened 6 months ago, a year ago. By the end, they will ask what they need. Eye contact. That's very, very contradicting of how the culture is here in the United States. I was trained to look at you when I'm talking, because in my community, we don't look at each other when we talk. And here is the opposite. I have heard many professionals say, oh, they don't respect, they don't pay attention, they look away, and they just want to avoid me. It's the other way around. When they look down or somewhere, they are paying attention, and they are not used to look at your eye when you're talking to them. So basically, in a real quick way, that is who we are as Indigenous people. That's how I grew up until I was 17 years old. Even though I came here, I went to school here, I'm still in close contact with my community. I go back every year to celebrate the day of the death in my village. I provide my tequio. Even though I am here, I send money back home to pay for my contribution in order to run the village. So, why migration? 2,000 miles from here, why did we find the United States? Many people say immigrants' fault. The migration of the indigenous people have been throughout history. We trade with other communities. We go to find jobs in other communities and easily go back to our villages when we have to, when we need to. And then in the early 1970s, probably before that, some people from our community came through the Bracero program. The rest learned, because we were in the deep south of the country, we learned very late about the Bracero program. But people started to still coming because they heard that there was job here. We face in our community very, very extreme poverty. When I was talking about the history of our communities, when the Spaniard came to this continent, that's a point that started for the indigenous people in a structural system to basically erase us as indigenous people. And it has, throughout history, it has been that. From government to family members, the way that we react, the way that we behave with indigenous people is very bad in Mexico. There's extreme discrimination against those of us that say that we are from the indigenous communities. Many people want to stay away from this. They don't manage to speak well Spanish. And they will say, oh, yes, I speak Spanish, I speak Spanish. And they want to stay as far as away from being an indigenous person. So, with migration, where you can find us? Indigenous people that are coming from Oaxaca, Guerrero are the newest wave of immigrants. And probably something that you may be aware about that contribute to the migration of our community is basically policies of the most powerful country in our continent. Policies such as NAFTA, the North American Free Trade Agreement. How many of you have heard about this? And what we have heard is basically that it has contributed in the plan to implement this policy was to, from what we heard initially, was to support each of the three countries that signed this agreement. But of course, who was in disadvantage? And instead of contributing to Mexico, and I'm just talking about my community because we had our lifestyles. We were farmers. We grew our food. We were able to maintain ourselves without having to migrate out of our country for thousands of years. But what happened with NAFTA? The subsidized corn in the United States has flooded the market. And we were producing corn. The price went so low that there was no means for us to continue producing corn. So it was no fair competence, if that's a way that you say in English, competition with subsidized corn. So we either had to stay in our community, die of starvation, or forcefully find a way to survive. And that's how we end up in the United States. Think about this, 5 million farmers were displaced in Mexico because of NAFTA. Now you can find us in the Central Valley because we were farmers. We don't have any other education to pursue other type of jobs, so we end up in the fields of California. In the Central Valley, Central Coast, San Diego, North Coast, that's where our community are located. And throughout history, we have suffered the same challenges. Racial hierarchy, class exploitation, cultural and language barriers. And that's what we have been dealing with for the past 20 years with the organization that I work with. The conditions of farm workers are very bad. And some of you might be aware of this. If you are descendant of Mexicans, the way that we do it is that we show our kids to go with us in the fields to get a taste of how hard it is as a way to push them to work. That's what I do with my children. Because many people are not aware of how hard it is, and they just want to take advantage. Many times, farm workers earn below the minimum wage. Legally, there's a minimum wage here in California, in the United States. In California, it's higher. But for farm workers, make sure they don't earn even the minimum wage. They're exposed to pesticides, exposed to the heat in the Central Valley during the summer, over 100 degrees. During the winter, very cold. And because of that, they cannot make enough to have a worthy housing. Living conditions, very bad. There are people living out in the streets. I'm sure Seth Holmes, if you were here in his presentation, mentioned some of this. But we don't want to blame the system as community of the challenges that we face. We like to organize ourselves. As I mentioned, back in 1980s, our organizers started to form smaller organization, village by village. And then in the 1990s, they started to form formal organizations, nonprofit organizations, and they combine their forces to implement programs that are very specific to the needs of the indigenous people. So, just to finish, I'm going to share with you some of the solutions that we see as community that could contribute to improve the lives, the health of our people. And probably something else that I didn't mention here is that after the 1986 immigration reform, there has been none other. So people that started to migrate after the 1986, the decade of 1990, 2000, they are here undocumented. And because of their immigration status, they cannot qualify for any programs that the rest qualify for. Talking about Medi-Cal, they don't qualify. Unemployment benefit, they don't qualify to get any of that. They contribute to their Social Security, the fake number that they purchased to be able to work, that they will not get back when they retire. Things that for US citizens, for residents, take likely for undocumented people is very, very hard. As organization, we advocate for the right not to migrate anymore. If there was opportunity in our community by our government for jobs, for education, for health, we will not have the needs to migrate. I go back to my village every year because that's where I belong. That's where my family members live. I don't want to stay away from them. But for people that do not, and that's because I'm lucky. I have the ways to move back and forth. For undocumented people, they have spent here for the last 10, 15 years without having to see their loved ones because they cannot come back once they leave. The government of Mexico provides a welfare system, like very small amount of money, just for the society not to raise up but not providing opportunity for us to learn and search how to survive ourselves. Ending the culture of corruption in Mexico. And probably not in Mexico only, in our government. We always advocate that instead of building a wall with millions of dollars to really contribute to our countries in a way to create jobs for us so we don't have to migrate anymore. But the system has been, because I have seen it firsthand, the idea of my dad when he came to the United States was to stay here at least or the most for 5 years, make a lot of money and go back home, stay there with his loved ones. I almost here for 30 years. I haven't seen that myself because that's my belief as well. One day to go back to my community and don't have to come to this place anymore. And with neoliberal, if that's how you say in English, gobierno neoliberal. The globalization, the multinational corporations from the US taking the resources that belong to us, just as they did with the native people here. That's what we advocate for. So I'll end here, and we want to continue with our next two speakers. If you had any question, maybe at the end, or how do we do this?
I think pressing questions now, otherwise we can take the questions at the end. Meileen has been an epidemiologist since 2000 with the Solano County Department, has worked closely with the Touro Public Health Program, and so we are honored to have her here as a speaker. Has worked many years. Acosta, aware of equity issues, exposure as a child to her father's work. Her passion for equity grew during graduate school. Meileen received her bachelor's degree in biology from infectious disease. Me and Acosta. Meileen and Renae Bajusman co-lead the next session. We'll further discuss this issue, equity, also further issues that were, public charge that we.
Hello, everyone. My name is Renae Alvarez Bajuzaman. Nice to see you all again. I'm with Meileen Acosta from Bar High, the Bay Area Regional Health and Equities Initiative. We are a coalition of the 11 local health departments in the Bay Area, charged with advancing health equity in the region. Go to the next slide, please. This is our mission to transform public health practice internally with the purposes of eliminating health inequities, using a broad spectrum of approaches that create healthy communities, such as these policy and systems change, which we were talking about earlier. Next slide, please. So we started the last one with this definition, and we always like to start with this grounding of what we know health inequities to be. This is the differences in health outcomes and mortality rates across populations that are systemic, unavoidable, unjust, and fair, right? These are sustained across generations over time and beyond the control of individuals and even individual organizations, and follow larger patterns of indifference within society. We'll go to the next one. So this is the Bar-High framework. I should be holding this closer. This is the Bar-High framework that we had. And I'm just curious, how many people were in the room the last time I was here? Great, really well-attended class. Fantastic. Okay, so we'll start in the current traditional public health practice on the right side of the screen, and that is what we're trained to do as public health practitioners, as clinicians, to address the risk behaviors of smoking, physical activity, right, disease and injury, that's our chronic disease prevention activities. But at Bar-High, we're focused on moving more towards the emerging public health practice within the living conditions, including the physical environment, the economic work environment, the service environment that includes your healthcare organizations and clinics, as well as moving further upstream to the institutional and social inequities. And that's where I'd like to start with this presentation. What Meileen and I are here to share our work at Bar-High is we're going to start here with the differences in immigration status. So we have immigration status. We would also like to expand this to Indigenous communities and differences within that. But we understand us representing local government institutions to be a part of the power indifferences, right? A part of the structural inequities that perpetuate over time. And if we flip that on its head and think about solutions, right, we can think about what we can do to change those policies, systems, and practices, and what we can do to advocate different laws and regulations, which we'll be talking more about with regards to public charge. And I'll just note, I think here, that this is hard, enduring work, and it requires strategic partnerships and advocacy and a collective effort. So I feel very fortunate and privileged to be working with such great minds like Meileen, as well as other organizations and community-based groups across the Bay Area to do this work. So this is our frog in boiling water. Do you guys remember this one from last time? Yes? Okay. So we'll still use this metaphor, and for those who are not here, the frog in boiling water, which is really pixelated here, but the point is you drop a frog in boiling water and it immediately jumps out because it knows it's hot. If you drop it in cold water and then slowly increase the temperatures, little bit by little bit, they won't recognize what's happening in their environment. And by the time it gets to the boiling temperature, it will surely meet its fate, the same way that it would if we just dropped it in boiling water. So what does this mean for our immigrant families and communities? This means that what we're seeing in our political and economic environment today, the anti-immigrant sentiment that's emerging and being emboldened by our current administration, that is the turn of the temperature. And not only that, we're at a boiling point, I would argue, or some would argue. So the question is, are we recognizing it? Do we know it's happening, and what are we doing about it? And that's what we're here to share with you of what we're starting to do about it, or what we are doing about it. Next slide. So I'll hand it over to Meileen to talk about our work within that.
Yeah, so thanks. So way back in beginning of 2017, we had a new president, new administration, and as Renae said, there was a lot of xenophobic, I guess, information being violence and racist violence out there. And also there's a lot of changes in immigration policy, right? And so way back in early 2017, what we wanted to do as Bar-High was look at the impacts of these changes at the federal level, but looking at the impact at the local level, right? Just because there are changes here in the federal level doesn't mean it doesn't have any local impact. It does have local impact. And so that's what we wanted to see. And so as part of our Barhai work, we wanted to actually look at the impacts, not on our staff, but actually on our residents, special immigrant population. Can you put next slide, please? So this was work that was done, that's why it says May 2017, it was work that was done way back then. And this is actually a survey. So we did a rapid response survey again. And this was a survey that we did along with the Public Health Alliance of Southern California. So Barhai is in Bay Area, and Barhai is composed of 11 local health jurisdictions in the Bay Area, and Solano is one of them. And so Solano is a member county, and I'm the data committee chair, so that's why I'm co-presenting with Barhai today. And Public Health Alliance of Southern California is composed of 9 local health jurisdictions in Southern California. And together, these two coalitions make up 80% of the state's population. Next, please. So again, so this was a rapid response survey. And so what we wanted to do was get information on what's happening out in the field so then we can develop local responses, right, local policies, but also look at regional, what can we do regionally, both at the policy, in terms of policies, and how can we also support some of the statewide policies that are being pushed out there. And so this was part of the survey. And the survey, again, what we did was we didn't actually ask the residents. We asked staff on what they're hearing and what we're seeing among their the clients that they serve, right? So we had a total of 157, okay. I'm on Epi who can't count. It's 207 total respondents, right? 157 here in the Bay Area, and then 50 respondents in Southern California. And as you can see, there are multiple types of programs who actually participated in the survey. Most of them are local health jurisdictions, health departments, and health departments here are all different, right? Some are mental health is part of public health. For us, it's not. Environmental health is part of public health in some counties, but here it's not. But here it's mostly, again, public health. But we also had some community partners, especially clinics, that participated in the survey. Next slide. So these are the results. So there were only 2 questions. We wanted it to be really short because we didn't want it to be really cumbersome for our staff, right, to answer. So two questions. One question is, have you witnessed or heard from clients that they have been impacted by the new immigration and refugee policy enforcement and public discussions since November 2016 in the following ways? So we gave them different options, and we asked them to check all that apply, right? And of course, as you can see, and what we've been hearing anecdotally, so all these we've been kind of hearing, right? Oh yeah, our services have been affected, we're hearing this, we're hearing that, but we never really had data. So this was like the first time that we actually got some data from our staff. So majority of our staff, of course, are seeing that our clients are afraid to continue or sign up for public programs, services, and or healthcare. Just to give you an example, our WIC, Women, Infant, and Children program here in Solano, there has been a 25% decrease in utilization. That's 25% decrease of utilization for our WIC program. So that's about how many basically children and infants and moms who are not availing of those services that are available to them, but they're afraid to get them. And then a majority also are suffering increased fear, stress, or other mental and emotional health impacts. So there's a lot of emotional health consequences. And then fear is a huge part, right? There's fear of detention and deportation. So parents are afraid that they're going to be deported, and then kids are also afraid that their parents are going to be deported and they won't see them again, so now they're left without a parent. They're afraid to leave the house or their neighborhood. They can't even go to the supermarket or to their job sometimes because they're afraid to leave the house. And then afraid of traveling. So as you can see, there's a lot really of mental health consequences of the immigration policies that have been enacted, and even some of them are actually just leaked information, right? They're not laws yet or policies, but they're just leaked information, but it's causing a lot of fear. Next. And then the second question that we asked was, can you tell us more about how a client or your program has been affected? So it's just a free text. And we put them into these 2, 4, 6, 7. There are 7 themes that we created. So of course, access to services, as I said, one of them is our WIC services. There's 25% decrease. And there's people are preparing for ICE, whether that's a parent preparing for an ICE raid, or kids kind of really preparing themselves. How do you prepare yourself as a child that about your parents getting deported? Fear of deportation, fear of providing information, especially to government entity. So as a government entity, of course, we have to ask information when they need to enroll, but they don't want to enroll because they don't want to give us information because they're afraid that we're going to give information to INS, and then they're going to get, and then the INS will come to their homes, or ICE. And then even back then, public charge has been mentioned, right? There was a leak of a memo. Actually, it was supposed to be an executive order of public charge. So it was leaked, and so it was causing a lot of fear. And then again, mental health. There's a lot of mental health issues. And I'm just going to read a few stories. But what I do want to tell you that when I was actually analyzing this data and looking and reading all these stories, it had a really huge emotional impact, because it's easy for us to stand here and pretend that these are data, but they're not, right? So these are stories of people in our community. This could be your family, your friends, or your neighbors. So just kind of keep that in mind. I'll read something else. So can you go put it back to the themes, please? Thanks. So access to services. I received a call from a client who was a single mother with 2 children. The client called to request cancellation of CalFresh benefits for her children, stating she feared receiving benefits would create legal issues for her in the future, which could result in her deportation. I informed the client and her information is not shared. However, client insisted we cancel her CalFresh benefits. Then preparing for ICE. I saw a patient recently at an evening clinic at a local school who was suffering from headaches. An interview and exam led me to believe these were related to stress. As we explored sources of stress for her, she revealed that neither she nor her husband are documented, but their only child was born in this country and is therefore a citizen. Should they be deported, she has no idea how she will deal with finding care for her child who is only 8 years old. Can you imagine you have an 8-year-old child, and what are you going to do? What's going to happen to your child if you and your husband get deported because of your undocumented status? And then a lot of this is causing isolation, right? You're fearful, you don't want to leave your house, and these already are population, these immigrants are already one of the most affected population, right? So they might be already feeling isolated. And so now we're adding on these things, so now they're feeling even more isolated that they don't even want to leave their homes. I've had several clients who do not want to come out of their homes to do simple living routines. It has become difficult to go shopping for food that they need due to being scared that they will be subjected to racial profiling that may lead them to being held up for questioning by ICE for deportation. The parents feel that their children might not see them again. So there's just a lot of these stories, and I'll just read one more thing, and then we'll go on to the next slide. Oh, okay. The children at our schools arrive crying because they're afraid that their parents may be picked up by ICE agents and they will not be returning school to pick them up. Parents who are dropping or picking up their kids from our schools have reported that they won't walk towards the school if they see a patrol car in the vicinity of the school. So again, these are just stories that we're hearing out there. But again, these are not just data, these are stories from real people. Next slide. Next. Okay. So from the data that we had, we decided, well, here are the data. What can we do as local health departments, right? What actions can we take to ensure that our immigrant population, actually, and even our refugee population, are still getting the care, are still getting the support that they need? And these are just a few things that local health departments have done after the survey. So they've done training, know your rights training or material distribution. So San Francisco has done that. In Alameda, they actually made a public statement that their health system is a sanctuary health system. And there's been a few other counties and cities have become sanctuary cities or counties. And Santa Clara actually created a partnership with an immigrant justice organization called Siren that they've asked to provide information and work with the immigrant and refugee population. So there's been a lot of partnership with organizations before that maybe they haven't really partnered with. And then there's guidance for health systems. Human Impact Partner, I don't know if any of you are familiar with Human Impact Partners or an organization based out of Oakland. They created a guide for public health and what actions local public health can do to actually support the immigrant population. And this was done with the help of Barhai. And it's actually a great guide if you guys have a chance to look at it. It's just a few pages long. And it's a great guide that goes through what we can do as public health employees to help our immigrant community. No, that's okay. We'll go to the next one because I do want us to spend a little more time on public charge. And then, as I mentioned earlier, there's a lot of mental health implications. And one of the things that Barhai is doing is they created an interrupting hidden bias, both in the community and in the workplace. And then also trying to build mental health capacity. And that's what Renae will give a little bit information on the next step that we did on another survey that we did among mental health directors and what public health can do to strengthen their mental health capacity.
Thanks, Meileen. So as Meileen said, we interviewed, we surveyed our staff. We found that behaviors were changing because of immigration policy, right? Because there was changes or fear of immigration policy. So we wanted to follow that, and we did that by interviewing our behavioral health directors across the region and staff. And what we found were some recommendations for building mental health resiliency within local health departments, as well as the philanthropy community and funders. So what we recommended from those interviews were providing the right support at the right time. This meant that we needed to ensure that our families were continuing access to services, building the capacity of staff and health systems to provide trauma-informed, culturally competent, and linguistically appropriate services. Increasing access to legal representation was particularly important, advocating for policies that protect immigrant communities, and then delivering welcoming messages that change the narrative, right? Next slide. So as Meileen had talked about the 2017 action steps that our local health departments took. This was another iteration of that in 2018, the following year. And you see we've started to move resources and investments into these strategies. So what that looked like from Alameda County, for example, is they developed an RFP process of $3.7 million in contracts to local community-based organizations and clinics to help fill the gaps of services. In Santa Clara County, this looked like $3.5 million allocated for legal services and deportation defense. That was the same in Solano County as well. Also dedicating staff capacity and staff time. That is also a resource and investment, right? Not just money in terms of dollars, but also money in terms of staff resources. So, for example, San Mateo County had dedicated their entire Office of Diversity and Equity to for all of the immigration policy changes, developing communication messages and outreach. It was also really important for our staff. I mean, we found this in the North Bay, on how to communicate about immigration, race, and racism, right? A lot of these policies come from systemically racist viewpoints. And so it was important that we were, as government agencies, educating ourselves as staff, as well as how to communicate with our clients. This included how to provide resources and information to clients on their Know Your Rights campaigns, and then mental wellness and self-care and support. Next slide, please. So now we're going to get into a specific policy change that has really large implications, we believe, and Meileen will introduce us into that.
So public charge, who's heard of public charge? So we're going to give a little bit more information and then later on go into what local health systems are doing in terms of this public charge. Oh, sorry. We do have to say that Renae and I are not lawyers. So this is what we know from reading the federal, it's actually in the Federal Register. It's really long. If you guys have insomnias out there, this is a good reading material. I actually tried reading it. So we're not lawyers, so we'll give you some information. But if you or someone you know have questions about immigration, I think please get advice from a reputable immigration lawyer. So what is public charge? Those who know about public charge, do you want to just say what it is in short, so we're not like here talking all the time? Yeah.
Well, I didn't understand it wrong, but that's when people are using government that supposedly are paid for the tax money into a charge to the public system, state resources.
Okay, cool. So that's actually, one piece of public charge. So you're talking about what Annette mentioned is the services that clients get or people receive, right, that are from government, and then that's basically being charged to government. Did I kind of summarize that correctly? Annette? Okay. So that's actually one piece of public charge. So really what public charge is, it's a test, they call it a test. It's an admissibility test to people who are either immigrating here to the United States or are already here and trying to get their green card. So it's a public charge test, and basically what it does is it looks at different factors, and then what it tries to determine is, in the future, how likely are you going to be how likely are you going to be almost like, to put it, a burden to the government? Like in your existence, in your day-to-day living, how likely are you going to be using the services from the government? So this is a public charge test. And it kind of goes into the self-sufficiency, right? So basically, the Department of Homeland Security wants to ensure that applicants for admission to the United States, so basically if you're coming into the US, or you're changing your status to be a lawful permanent resident, basically into a green card, you're subject to public charge ground of inadmissibility or self-sufficient, right? So of all the resources that you have, how likely are you going to be that you're just going to be relying on yourself or other organizations or your family and not on the government? And if you're determined to likely be a public charge, basically, then the government can deny you admission to the US or can deny you getting a green card. And public charge is not something new. It's actually been in practice and in law for hundreds of years. It's just that there hasn't really been good definition of what public charge is and what the benefits are that would qualify you as a public charge. So as I mentioned earlier, availing of those services from the government is one factor that they look at, but there are also other factors that they need to consider in public charge determination. So they call it the totality of circumstances, is that right? And so they look at your age, family status, education, health, assets, resources, and financial status, and skills. So you as a person looking at all these factors, how likely are you going to be a public charge? So that's what the public charge is. We'll go into a little bit more detail about those factors. And then in terms of the benefits that are factored into the determination, that's kind of what Annette, I think what you were kind of mentioning earlier. There are two. There's a cash benefits. So if you're receiving SSI, CalWORKs, or general assistance, and also if you're at a long-term care facility at the government expense. So these are the public benefits that are also being used as factors in determining, along with all those other ones up there in your public charge determination. Does that make sense? Okay. Oh, yeah.
Okay, cool. Okay, so thank you, Meileen. So Meileen went over the current practice the rule as it currently stands. On October 10th, the Department of Homeland Security proposed a new rule. Okay, so the current practice, when is the public charge test administered? It's administered when immigrants apply and enter the U.S. from another country, or when immigrants apply to become lawful permanent residents or get their green card status, as was mentioned before. In the new proposed rule, they still do this test, but they've also will do the test for non-immigrants requesting visa extensions and changes in their visa status. So this is a difference in the current rule and the proposed rule. The proposal, I think, October 10th? Sure, so the background on the proposed rule, several versions were leaked, I think maybe 3 since 2017. So there have been several immigrant legal groups and other community organizations that have been organizing and preparing for the rule changes as they came down. So when the final rule changes were published in October 10th, we were ready. And so that's why we were able to move quickly and have so much advocacy efforts in partnership with others. Thank you, Meileen, for that. Okay. So immigration is a process and a pathway, and there's several different pathways in that process. And so here's some people who are exempt from taking the public charge test. So these are folks who are refugees and asylees and other protected classes within immigration. It includes most legal permanent residents as well as U.S. citizens, and again, some protected classes listed here. Backwards. So as Meileen mentioned, we don't look at just, I know there's a lot of information. We don't look at just if they're using public benefits or not, but we look at the totality of the individual and their circumstances. So that includes their age, and this is, are they primed for an employment? Because, right, we're trying to determine if someone is going to be employed and be able to be self-sufficient on their own. Also within their financial status, this is where we're asking about public benefits and what they're using. And I'll go over what the proposed changes to the definition are. Health, if you have any physical condition that is precluding you or interfering with your ability to attend school or go to work. If you have subsidized health insurance, that's Medi-Cal or Medicare Part D. Your family status, do you have children or dependents who may also need your support? Assets and resources, they're looking at if you have enough assets or resources and weighing up as a positive factor. And they've listed out the rule of 125% of the federal poverty level, which is about $31,000 for a family of 4. The assets and resources, and I'll go over this again, carries the most weight out of all of the factors. We'll see how that applies later on. They also look at the education and skills of an individual. So this is the totality of factors that they look at when they're determining their public charge test. Next slide. Okay. So this is the proposed benefits that are considered. So as Meileen mentioned in the first top, the current rule stands. They look at cash assistance programs, that's SSI and thank you, and long-term care in the government, thank you. But this right here is where they've expanded the definition. Okay, so now we're looking at not just cash and long-term care expenses. Now we're looking at if people are in nutrition programs, if people are in housing programs, and if people are in healthcare. So that is our SNAP, CalFresh folks. That's people who need housing supports from Section 8 rental assistance and subsidized housing. And that's our Medi-Cal population. Except for emergency medical conditions within Medi-Cal. And then the Medicare Part D low-income subsidies. This helps older adults pay for prescription drugs. The Children's Health Insurance Program is not a part of the rule. It was purposely left out. However, they've asked, should it be? They've requested to get some comments on that. And if you just kind of think about that within children, are you even able to distinguish between the differences between a child and their parent? Or is that family system really connected, right? So under this rule, we can go to the next one, I think. Oh, thank you. Currently, this proposal does not include WIC. Previous leaked versions had a lot of things that this included, but right now, it does not include WIC.
I was just going to say, there's the expansion of this public benefits, right? And this is what's causing a lot of fear among our immigrant population, even those who are documented. Even those who already have their green cards, right? They're not subject to the test, but they're scared because there's a lot of misinformation out there, especially with this expanded benefit consideration. So it's just from a limited benefits to now a lot more.
Thank you. Okay. So the Department of Homeland Security, who published the rule, DHS, proposes to consider that these factors listed are weigh heavily negative, because they are indicative of the likelihood that someone will become a public charge, all related to employability, right? That includes someone's lack of employability, whether they receive one or more of those public benefits, so that's housing, nutrition, and Medi-Cal, within 3 years of filing an application. If they have a health condition that may interfere with their ability to work, if they had no private insurance, or if they've been found previously inadmissible or deported based on public charge. So those weigh heavily negatively. having trouble with that today, in the determination. The heavily positive, the one heavily positive that you can have if you're doing this test is if you have money. I'll say that one more time. The one heavily positive thing that for the public charge test is if you have money. Financial assets of at least 250% of the federal poverty level, or supports and resources that equal that amount. So DHS recognizes that not everyone who is able to work will work, right? Some people may have sufficient resources within their households, for example, and they would recognize that as the totality of the individual. Next slide, please. Yes, please.
The one thing, though, in reading the proposal is that these are all weighted. However, they don't actually say, like, what is the equation, right? How much just this, if you have all those heavily negative and you have this one heavily positive, I don't know if you actually can anyway, but they don't say basically what the equation is. Like, well, how do you factor in all these different, its weights, right? And so I don't know if it's still gonna be subject to, is it still gonna be subjective? Right, like, you're gonna say, yes, I qualify, and then you admit me, and then, like, you know, when I go to you and I have the same exact information, and you're gonna say no. So I think it's still a little bit vague on how they're actually going to weigh all these things. Would one heavily positive outweigh some of those, not necessarily heavily negative, but some of those negative factors? So it's still kind of confusing.
Mm-hmm. So what are the health impacts of proposed public charge rule? We argue that this increases our state, our region, and our nation's health risk. Let's back up. California is home to 10.7 million out of the nation's 43.7 million immigrants. That's the largest number than any other state. It's California. So this rule weighs heaviest on our state. And the number of parents who are U.S. citizens who have been admitted as lawful permanent residents has tripled, more than tripled between 1994 and 2006. So we know that this is inherently our community within California. The research has shown that chilling effects discourage millions of folks from accessing critical health services, services to feed their families, services to stay housed, and services to provide necessary medical care. So if you're thinking about the interconnectedness of families, of systems, of communities, you see that this extends beyond just immigrant populations, but to U.S. citizen children of immigrants, other citizens who are members of immigrant families, and those exempted refugee and asylee populations that we mentioned earlier. So reduced access to essential health services leads to worse health outcomes. I feel that I'm preaching to the choir in this room, but we see this within maternal child health, with education, mental health, poverty, increases of hunger, unemployment, and homelessness. So that means that people are more likely, more difficult in reaching their own self-sufficiency and maintaining work if they're not healthy, if their families aren't healthy. And furthermore, threatens the health and the strength of our entire family units, of the familial networks that support one another, woven into and provide a lifeline for our communities. And also of note, this is a disproportionate impact on our older adults and people with disabilities, and not considerate of the role of grandparents, for example, and other family members who provide caregiving roles. So, next slide, please. So beyond our increase of our health risk, we are further worsening our health and racial inequities, right? Health inequities, which are the differences that are systemic, unfair, avoidable, and unjust. So we know that this amplifies for our low-income communities and our communities of color, that in California, this is especially true because we have a housing crisis here in the Bay. That's what I talked about last time that I was here, was climate change and our housing crisis. And that our local health departments have recognized that housing stability and affordability is a vital health issue. And so eligible families who need a little support and need a little help are less likely to seek care and less likely to seek housing and homeless benefits. So stable housing also plays a critical role, not just in healthcare, but also employment, school enrollment, and community safety. And we know that in the Bay Area, young families are twice as likely to be evicted, and also eviction is a leading cause of homelessness, right? So these are complex social issues that require more investment, not less. So when we looked specifically at who this would impact the most, we saw that Latinx families, and I apologize, it's not understanding of the nuance here of the diversity of our immigrant communities, but Latinx families were found to be disproportionately overrepresented in those income groups that are more likely to be public charge, lower income groups, right? When we pulled out the data, we found that out of the 1.8 million non-citizens below that percentage of the poverty level, the 1.4 million are Latinx. And then out of the 3.6 million non-citizens with their family members, so that interconnected system that can be impacted by the public charge rule, 2.9 million are Latinx. And then and more recent research that was published, that Meileen found, just published, I think last month, from the Migration Policy Institute, found that people from Mexico and Central America specifically are at higher risk of denial of admission to the US in their green card status than those from Caribbean, Asian, South American, Europe, and Canadian countries. So not only does it it increases our health risk and worsens our health inequities, but it impacts our entire healthcare system. So this means an increased use of emergency rooms and expensive medical care, as well as uncompensated care, and also known as charity care, and stresses our overall safety net system. And by not including the strength and the collective strength and wellness and values of the Latinx populations, we undermine our overall health. Next slide. So in conclusion, here are the key points from the public charge rule. 1, it dramatically changes the definition of public charge to apply to anyone who is more than likely to use a minimal amount of certain cash, health, nutrition, and housing benefits. 2, it applies a similar test to bar extensions of non-immigrant visas and changes of immigration status, so for changing from a student visa to an employment visa, for example. 3, families are less likely to seek or accept support to be healthy, nourished, and be active in their community. And 4, and maybe this is the most important, is that the rule is not final. So in this process, that means that the rule has been published. They're seeking public comment. And what I really appreciate about this process is that you don't have to be a citizen to submit comments. Anybody can submit comments. All of you can submit comments. And they are accepting them until December 10th. The Department of Homeland Security must and is mandated to review all unique comments before publishing the final rule. So this means that more comments, the better. It takes them longer to answer. It takes them longer to answer. And you guys are all students in research. You've got data. I'm sure you have plenty of data. You can cite all of that data. You can submit all of that data, and then they have to review all of that data. So I really strongly encourage you to submit, and we won't leave you hanging. We'll give you some places that have good language where you can adopt from. And so the theme of this session is solutions in the face of challenges and changes. We've talked about some of the work that we've done within our counties, and I'll just highlight the two in the front here that put together economic and fiscal estimates of the impact of people disenrolling in their benefits, right? Because if you know the Medicaid system, that's a federal match system, and that means that that's less money for counties. So Alameda, for example, quoted 29 to 59 million in annual impact, and San Francisco wrote a letter to the Office of Budget Management and Budgets to go over their impact, which is 129 million to 368 million estimated a year.
Survey, has anything similar been done in other states, either just states that have smaller immigrant populations or simply further away from the border? I'm just curious if sentiment differs with those two criteria, that's all.
Yeah, funny you ask. I was actually contacted by Chicago about this because they were actually thinking of doing a similar thing in Chicago. So I gave them our short survey. I don't know, I didn't follow up with them whether they actually did it or not, but I know they did create like a day-long symposium, and they were going to use some of this data for that symposium. But another study, though, that's not necessarily this rapid response, but Kaiser Family Foundation actually did a bigger survey, not survey, but bigger, they did informal interviews and focus groups, actually, around the country. And ours was like, small, and it was really quick. But the findings that they had were basically the similar findings that we had: a lot of fear, a lot of immigrant population dropping off their services. So it's a bigger one, I said, but it's a similar findings.
Additional questions? There.
I don't even think I need this. That's okay. Thanks. Can you hear me?
We're recording.
Thank you. Thank you, first of all three of you, for your wonderful presentations. I actually just graduated from the public health program here and absolutely loved it. And I met Meileen through the public health program. So all of you have an opportunity to work with a lot of these wonderful people that you get to hear. Okay, that aside, you mentioned the in the public charge section, you mentioned the new proposal that may affect non-immigrants' visa status. And also something to consider for all of the health professionals. This includes groups of students, medical students, osteopathic medical students, nursing students from a lot of other countries who are actually willing to go to places where Americans and American citizens don't want to go and practice, which is rural areas. So this is affecting a lot of not just immigrants, which of course it does, but also the rest of the country. So everybody is affected by all of these changes. And are you guys looking at the proposed public charge consequences as affecting policy change, not just locally, but also, like you mentioned, working with potentially Chicago or other public health departments? Thanks.
Thank you for the question. Great question. Are we tracking the consequences of public charge changes, right? Yes, we already are. We're already seeing that. Like without the rule, without it being published, without being implemented, it's already changing people's behaviors. People are not going in the clinics. People are disenrolling in services. They are not taking their kids to school. They're not going to the grocery store. Like it's actively changing people's behaviors. And so we're seeing it in that capacity, and we'll be continuing to monitor it through each of one of our agencies. Anything else, Meileen, you want to add to that?
The question was on changing some of the policies. Is that what it was, Leela?
Work is so important in terms of tracking and the data that's being collected over time. So even with the fact that this proposal is not enacted, there have already been changes in tracking. And but I'm assuming that will, as time continues, and as these drops, and as these consequences of this proposal continue, that you'll be able to file this data and take it to the counties to then hopefully
Develop policies.
counteract whatever ends up being
Yeah.
or to effectively whittle down
Yeah.
on a federal level if there's not tracking.
Yeah. So thank you actually for also you were listening on at least like who's affected. Like you said, like there might be students here who are on a student visa, right? So it might also affect you if you were planning on changing that visa into into basically an immigrant visa to stay here and work. For residency, right?
Residents from countries like Iraq
Yeah.
have been practicing in Iowa and South Dakota and Nevada and Idaho and a lot of other roles.
So then at least in terms of policy change, most of us are at least changing local policy. We rely on BARHA and other organizations to do the advocacy for the national policy changes, right? But at least here locally, there like a lot of health departments are already changing their policies and even their practice, having the policy of creating a safe kind of space, right? Because then ICE can come into a safe space. So just little things like that, or even just welcoming signs. I know it might seem small, but maybe for an immigrant who at least they feel a little bit more welcome. And I think a big thing that Leoncio mentioned earlier is cultural training are not just the providers, but really any staff who is public facing to really train them to be culturally sensitive and, okay, I'm gonna say this, and not really be racist. It's part of what I do in Solano County is racial equity, right? So we're also looking at our policies. What are the racist policies that we have in government? And how can we change it? And how are we perpetuating these policies that we have? So that then, how can we address it and change it so that it's not affecting our communities? So just smaller local, again, policy changes.
How is the government framing it from their perspective, the public charge reform? Is it like a bottom line financial move? What's their frame on it?
That's a good question. How is the federal administration framing this policy change? I think it depends on which part of the administration we're talking about. This was put forth by the Department of Homeland Security, which and is a part of the Immigration and and Naturalization Act. So within immigration reform, I think is an entirely different sentiment than what's happening with like in Health and Human Services or the criminal justice system, for example. Right now, it is hotly contested. I can say that within, it's been leaked several times since it came out from someone within the agency, right? At least 4 times since 2017. And we're, again, very organized and connected to advance that. So I think that's a tricky question. It depends where. Good question.
This might be a partial answer to it. So there was, in 1999, there was, they came up with a definition of a public charge. And back then, I think what they were thinking of, at least in terms of public benefits, are something that can be monetized, right? Like the cash benefits, it's like monetized, right? And then the long term, you can actually put money in it. And so I think way back in history, that's what they've thought of as benefits. So the proposed rule is basically them trying to really define a little more what public charge is. And then in terms of it's not just then people on SSI or TANF anymore or general assistance, then, the government also has all these other public benefits now, right? Like SNAP Ed and the housing voucher. So there are all these benefits now that the government pays for it. But at that point, it wasn't being calculated or part of public charge. So now they're saying, well, that is still coming from the federal government. Yes, it's not cash, possibly cash that you're getting, right? But it's still a benefit. So now we have all these other programs and not just 3 programs before. So now we're going to change it to actually include all those benefits. So I think, so it's really, I don't know, for them, maybe it is, I don't know if they save money, but really it's, their thinking is, we want to define it more. So that's kind of their reason for the proposal, is they want to define it a little better. But I have a personal belief on that, but that I won't share.
I probably will. So what I think is kind of getting back to your discussion about culture and value, and a lot of the things that you were talking about Indigenous people and the values of working together and supporting each other for the public good. I think this monetization of people that are specifically designated as the other, people from outside, and they're chosen, they're not the people from Norway or Ireland, and how much they're costing us. So I think it's not looking at the positive benefit, it's not looking at the humanness and the history that we were just, Gail and I were talking about, well, what about just giving California back to Mexico as just a joke? But the idea that historically California was part of Mexico, and that there's, a rich history of cultures collaborating to create the life that we love in California that's not new, that has to do with all kinds of creativity and nature. And so I think that the other view of this is it's making people not human. It's making people not seeing their value. And you could negatively monetize any of us and it wouldn't look good, on what we cost if you like you melt people down. I have very strong feelings, you can tell.
And just to add to the conversation, I think that it's also a weakening of government. And I think that has a really strong sentiment within this administration and larger implications. Any other questions or comments or reactions? Sure.
My question is for Leoncio. I think you did a great job kind of in creating an indigenous perspective or sharing an indigenous perspective on migration and immigration, and I wanted to see if you were interested in expanding a little on the unique challenges and obstacles for indigenous people from Mexico and Central America versus white or non-indigenous folks that are immigrating from those same regions.
Yes, that's a great question. Some of the challenges that directly affect my community is culture, basically. Having all this knowledge, all this culture, and then moving to another place that is not aware of who we are, we keep ourselves very isolated, afraid to get out, stay in the place that we already know in farm work, and not even pursue like a higher education. Because of language, we cannot communicate with people, even those who speak Spanish. Immigration status, we cannot qualify for programs that other people qualify for their children, even for health, for housing. What you were talking about, Section 8, people cannot qualify for those. Medical, except emergency medical, that do not serve anybody unless they are dying. Health. We combine or we approach the traditional way of healing because that doesn't cost us too much. But the migration basically changed our diet. And diabetes, for example, 10, 15 years ago, we didn't know what it was. 10 years ago, started to rise in our community. We didn't know how to handle it. And we know now that it has to do with Western medicine. But it is too late. Being exposed to pesticide, heat stress, all these are the challenges that we are facing. The change of diet, as I mentioned, we used to grow our own food. Now we have to eat processed food that basically change our health and the type of diseases that we suffer. We know how to handle susto, those of you who speak Spanish or Hispanics, Latino, mal de ojo, caída de la mollera. We know those illnesses, ethno-specific illnesses. Well, but when we're talking about asthma, diabetes, cancer, now many people in our community are dying of cancer. And we don't know what is causing this. But of course, what we eat and being exposed to the heat for a long time, being exposed to pesticide. Pesticides do not kill people. That's why we're here. But if it kills living things, sooner or later we will die.
And I'm an immigrant myself. I came as a student many years ago, so I know the charge issue very well. When I first came here, every year I had to certify that I have enough money so that I don't become a charge, public charge. So this term public charge has been with me for more than 40 years. So one of the things that solutions that you proposed was ability not to immigrate, which I think is a very powerful solution. If in our communities we had our resources that we can access our own way, we would not immigrate. The question is, to you is, how do you see that happening in your community? What is it that you can do so that people from your community do not have to immigrate and face all these odds that they're facing in life?
Well, for us, we continue as a social organization, political organization, working at the grassroots level to educate those who stay home that migration should not be like a need. It should be an alternative. And hopefully, I mean, we have high expectation from our elected federal government in Mexico to change all this, because that's the discourse. That's what the campaign was throughout, of creating jobs in Mexico so we don't have to migrate. That has been our advocacy work for the last 20 years, that migration has forced us basically to get out of our community, but that we need to find ways to create community projects as a way to create economic opportunity for our people and do not migrate anymore. That's what we are working on. But hopefully, with this change of government, that will help a lot. Because the last 6 terms has been to follow the economic system that the U.S. has set up.
Are there a wonderful conclusion to our speaker series? And I really appreciate our speakers coming in and posing solutions. What we hope for in the public health program is that we give you more than just a course in epidemiology or health equity, but we give you a foundation to context and practice in the world. You're only here with us for a short period of time. And what we hope with this series is that we give you a context in which people live, work, and play. You've heard that before, but it's really important as you go forward and represent the communities from which you come. Also, we hope that you represent Touro. So we will see you, or at least some of you all, next fall as you decide to take this course as an elective. And I will see the majority of you in spring. Thank you so much.